Welcome to this video where we are going to discuss the recalled questions from pediatrics in this NEET PG 2022 exam. So this time, there were more than 21 questions from pediatrics and the questions were pretty straightforward. So if your basics are clear and your concepts are clear, if you've gone through the important topics, I'm sure you must have been able to answer all these questions. So let's discuss the very important topics from pediatrics. So an infant is admitted to ICU with complaints of recurrent jerky movements, of the limbs and the EEG showing hypsarrhythmia. And we know this hypsarrhythmia on EEG is suggestive of a condition known as West syndrome. So what will be the antiepileptic drug of choice? So we know for West syndrome, the drug of choice is injection ACTH or adrenocorticotropic hormone. So that is the best answer out of the given options here. Now this we have also discussed in our pediatric videos as well as notes. You can see that hypsarrhythmia, developmental delay and infantile spasms is a triad that is seen in West syndrome. And the drug of choice is injection ACTH. While if there is infantile spasms in a child with tuberous sclerosis, the drug of choice then becomes vigabatrin. Moving on to the next question, which vitamin deficiency gives rise to the following picture? This, friends, you can see clearly is a bitot spot, which is a triangular shaped lesion like this with a base towards the cornea. So this bitot spot is a feature of vitamin A deficiency. So vitamin A, again, we have discussed in detail in our videos as well as notes. You can see the earliest symptom of vitamin A deficiency would be night blindness, while the earliest sign would be conjunctival cirrhosis. And there's a WHO grading to it also. And what we saw here was X1B stage, that is the presence of bitot spot. Another very important often asked question in this regard is what is the dose of treatment for vitamin A deficiency. So we need to know the treatment or therapeutic dose of vitamin A deficiency. So it depends on the age. If the age is less than 6 months, then the dose is 50,000 units. If it is 6 months to 12 months, it is 1 lakh units, and more than 1 year of age, the dose is 2 lakh international units. And you need to give a dose at the diagnosis and repeat a dose 24 hours later and then repeat another dose 2 to 4 weeks later. Moving on to the next question. What you have here is a mother who reported that the baby did not pass urine on postnatal day 1. What will be the next step? Now, friends, for this, we need to know the normal physiology of newborns. So this is what Loherty Newborn Care in the latest edition says, that each urine and stool output. So, the baby's first urination should occur by, so if you can see clearly, the first urination should occur by 48 hours of age, and first passage of meconium is expected by 24 hours age. So till 48 hours, if the baby has not passed urine, then this delayed urination or stooling will be a cause of concern and must be investigated. But friends, in the given question, it has been mentioned that baby has not passed urine on postnatal day 1. So day 1, we need not do anything else. Continue breastfeeding and observe. And mostly the baby is going to pass urine within 48 hours. If it doesn't, then of course we need to take the baby inside the NICU and investigate. Moving on to the next question. This is a repeat from AIIMS November 2019 question. So regarding high-risk infant, which of the following are correct? Weight 2.5 kgs or birth order more than 3 or single parent or artificial feeding or birth weight less than 85th percentile. So before going to the options, so we've already discussed what are the factors to define high-risk infant in our video where we've discussed the AIIMS November 2019 questions. So there are some maternal or social factors. So high-risk neonate means any neonate who has more chance of morbidity or mortality as compared to any other normal newborn. So there are some maternal factors like if the mother's age is less than 16 years or more than 40 years, or illicit drug use like alcohol, cocaine, smoking and all. If there is poverty, if it is an unmarried mother, that means a single mother. Short interpregnancy time, that means the birth spacing is not there appropriately, too many children at small intervals, and maternal diseases like diabetes, hypertension, rheumatological illnesses are a risk factor. Related to previous pregnancy, if there has been an intrauterine death or neonatal death or IUGR, prematurity, hydrops or congenital malformation or IEM in the previous pregnancy. Related to present pregnancy, if during pregnancy mother has vaginal bleeding, twin or triplets or quadruplets, or preeclampsia, premature rupture of membrane, poly or oligohydramnios. During labor, if you have premature or postdated labor, if there is fetal distress or breech presentation, meconium cell liquor, assisted delivery or cesarean section, these all are risk factors making the baby high risk. And related to the neonate, if the birth weight of the baby is less than 2000 grams or more than 4000 grams, or if the baby is preterm or postterm or small for date or large for date, and if there is respiratory distress, congenital malformations or pallor. So coming back to our question, so what are the high risk factors here? Let us see. So weight 2.5 kg we know is not a high risk factor because less than 2000 grams we saw makes a baby high risk. Birth order more than 3 again is not mentioned as a high risk factor, though birth spacing, if it is less, then it again is important. So single parent, yes, unmarried mother we saw was a risk factor. Artificial feeding, though not mentioned in this list, but we know breastfeeding is protective and it has so many advantages for the baby. So if a baby is not breastfed, then definitely the baby is at risk of having complications like sepsis and many other conditions. Okay. Now, birth weight less than 85th percentile again is not a risk factor. We saw a baby if it is small for date. What does small for date means? Birth weight less than 10th percentile of expected according to gestational age. That baby will become high risk and not with a birth weight less than 85th percentile. Okay. So, the best answer out of the given options is choice 3 and 4, that is single parent and artificial feeding. Okay. So, moving on to the next question. Multiple fractures detected in antenatal ultrasound scan. What can be the diagnosis? Now, out of the options, achondroplasia we know is a condition where the baby is, there is short stature and there is short limb dwarfism, but there is no increased risk of fracture as such in achondroplasia. Osteogenesis imperfecta we know is a collagen defect, and collagen is very essential for bone formation. If collagen defect is there, bones are fragile, and yes, there is increased chance of fracture in this condition. And in some severe types of osteogenesis imperfecta, even antenatally in utero, you can find fractures in the baby. Okay. Marfan syndrome we know is a condition where the fibrillin gene is affected and there is tall stature and there can be some skeletal abnormalities. Arachnodactyly is there. You can get pectus cavum or excavatum, or you can get in Marfan syndrome you can get the lens dislocation of the eye and so on. Cretinism is again a condition where there is hypothyroidism. There can be short stature, but there is as such not much increased risk of fracture. So out of the given options, clearly osteogenesis imperfecta is the best choice. Again, we've discussed it in our videos and in our notes. You can see it is a collagen defect and there is a triad of blue sclera, deafness and bony deformities. And this bony deformities, friends, is due to the recurrent fractures that happens in this condition. Okay. So you can see in this antenatal ultrasound, can you appreciate that the bone is broken? There is the broken femur and the broken humerus, and there's a 3D reconstructed view. Okay. So clearly you can see the broken bones here. Moving again to a very straightforward question which we've discussed n number of times. Which of the following diseases is autosomal recessive inheritance? We already mentioned osteogenesis imperfecta has autosomal dominant inheritance. Treacher collin syndrome also has autosomal dominant inheritance. Achondroplasia is also classically example of autosomal dominant inheritance. So cystic fibrosis is the best answer of the given options which has got autosomal recessive inheritance. Okay. Now autosomal recessive disorders we've already seen there's a mnemonic ABCDEFGH. So albinism, beta thalassemia, cystic fibrosis, deafness, emphysema, Friedreich's ataxia, Gaucher, homocystinuria, some diseases with autosomal recessive inheritance. Moving to the next question, what you have here is a child with exercise fatigue who presented to the OPD. There were features suggestive of McArdle syndrome. So, there you can get myoglobinuria and, muscle weakness in McArdle syndrome, which is a type of glycogen storage disorder where predominantly muscles are involved. Which of the following enzymes is deficient? We know in McArdle disease, muscle phosphorylase is deficient. Another name for muscle phosphorylase is Myo-Phosphorylase. So, that is the best choice out of the given options. Glucose 6-phosphatase we know is deficient in von Wiersbe disease, lysosomal glucosidase or alpha glucosidase in Pompe disease, phosphofructokinase in Tarui disease. Okay, so these are the muscle glycogenosis. You can see Pompe disease, we already mentioned McArdle disease, muscle phosphorylase, and Tarui disease, phosphofructokinase. Okay. And most common GSD in children is von Wiersbe, while in adolescents it is McArdle disease. Moving on to the next question, a child presented with hepatosplenomegaly, mental retardation and bone pains. Bone marrow biopsy showed crumpled paper appearance. Which enzyme is deficient? Now classically we all know, friends, so many times we've discussed that crumpled paper appearance is seen in the Gaucher cells. Because of the deposition of glucocerebroside in the cytoplasm, you can get this crumpled tissue paper appearance of the cytoplasm. So in Gaucher disease, the enzyme deficient we know is glucocerebrosidase. So that is the best answer here. We know glucose 6-phosphatase deficient in von Wiersbe disease, hexosaminidase in Tay-Sachs, and beta-galactosidase in GM1 gangliosidosis. Okay, so the best answer here is glucocerebrosidase. Gaucher disease, you can see this is the Gaucher cell where the cytoplasm has got the typical crumpled paper appearance, and deficiency of glucocerebrosidase is there. Classical clinical features are splenohepatomegaly. You can get bone pains or pathological fractures, pancytopenia because the normal bone marrow elements are replaced by Gaucher cells, and neurological features may or may not be present. Okay, moving on to the next question. An 8-year-old male presented with to the OPD with purpura over the lower limbs and buttocks. He also reported having arthralgia, that means joint pains are there, and abdominal pain is also there. There was a previous history of upper respiratory tract infections. What's the treatment option? So friends, here the diagnosis. What do you think is the diagnosis? So this appears, so purpura are there mainly on the lower limbs, also associated with joint pain and abdominal symptoms, and there's a prior history of upper respiratory tract infection. So this is a disorder that is Henoch-Schönlein purpura. So Henoch-Schönlein purpura, most of the cases are going to resolve on its own. Some cases, very little, 10 to 20% of cases which do not resolve or which have severe manifestations, including severe abdominal manifestations. So in those cases, we might need to give glucocorticoids. While in a very small number of patients, because of the renal involvement which is there in Henoch-Schönlein purpura, glomerulonephritis may be seen in up to 1/3 of cases. There you may need to give other disease modifying agents like azathioprine or methotrexate or cyclosporin or cyclophosphamide. But here, so most of the cases of HSP will resolve spontaneously. If not, then glucocorticoid is the drug of choice, especially if there are abdominal manifestations or any other manifestation of severe illness. Okay. So Henoch-Schönlein purpura, again, we have discussed the diagnostic criteria already. Palpable purpura with presence of any one of the following, including abdominal pain, arthritis, arthralgia, any biopsy showing Ig deposition or renal involvement. And remember, even though it is a purpura, it is due to vasculitis and thrombocytopenia is usually absent here. Okay, so moving on to the next question. What you have here is a 4-month-old child of an HIV positive mother who presents with recurrent diarrhea. What will be your next investigation? Whether you'll check for giardiasis or check for HIV P24, or you will stop breastfeeding and start HART, that is highly active antiretroviral therapy in the baby, or HIV RNA PCR on dried blood spot. So friends, here the baby, we don't know the status of the baby. The mother is HIV positive. But basically, we need to know whether the baby is also HIV positive and is having HIV disease or not. So, because that, if that is present, could be contributing to the recurrent diarrhea and needs treatment. So, check for giardiasis. No, rather, if there is recurrent diarrhea in a baby with HIV, we will suspect, infection by atypical organisms like Cryptosporidium, Isospora, and so on. Check for HIV P24. No, we know antigen-based tests are not very accurate in infant babies less than 18 months of age. We will rely only on PCR. Stop breastfeeding and start HART? No. We know, especially in developing countries, the benefits of breastfeeding far outweigh the risks that it confers. Okay. So stop breastfeeding. We will not advise in this situation. And, starting the antiretroviral therapy without knowing the HIV status of the baby, again, is not a very viable option. So HIV RNA PCR on dried blood spot is the best answer out of the given questions. And friends, in our video and notes, we've already discussed the preferred test in infants or neonates are in born to HIV positive mother, HIV RNA PCR or HIV DNA PCR or culture. And in breastfed babies, we need to do retesting later once breastfeeding has been stopped. And prophylaxis for infants born with, to mothers with HIV, we know we need to give nevirapine or zidovudin for at least 6 weeks and so on. Okay. And antiretroviral therapy should be initiated in any baby who is HIV positive, ideally. Moving on to the next question. Again, a very, very important, often repeated topic. Okay. So pentavalent vaccine. So recently only it has been repeated. In the NICT also it was there. Pentavalent vaccine and MR vaccine vials were open and cold chain was maintained and vaccines were not expired. What will you do with these open vials? Whether you will discard both or discard pentavalent, use MR, or discard MR and use pentavalent, or use both MR and pentavalent. So for this, friends, we need to know the open vial policy, which is very, very important, which allows the reuse of the partially used multi-dose vials in subsequent immunization sessions. Provided the expiry date has not reached, the cold chain is maintained, date of opening the vial is clearly mentioned, aseptic technique has been followed to take out the vaccine vial septum has not been submerged in water, and open vial policy we need to know is applicable for certain vaccines only, like the T series vaccine, the hepatitis B, pneumococcal vaccine, pentavalent, and the polio vaccines. While open vial policy is not applicable for measles containing vaccines, BCG, rotavirus, or Japanese encephalitis. So moving back to our question, what we have to do here is we have to discard the measles rubella vaccine because open vial policy is not applicable for it, and we can use the pentavalent vaccine. So C is the best answer of the given options. Okay. So next question, friends, was a question on rheumatic heart disease. There was a 11-year-old girl who presented with sore throat and streptococcal infection 20 days ago, followed by fever was there, arthralgia, and elevated ESR. There is no evidence of carditis or residual heart disease. What is the correct option with regard to prophylaxis? So here, friends, you have, the modified Jones criteria is being satisfied because there is arthralgia is there, which is a major criteria. in countries with high prevalence of rheumatic heart disease. And two minor criteria, that is fever and elevated ESR is there. So this is a case of rheumatic fever, and you need to start secondary prophylaxis in the form of injection benzathine penicillin. You also have the antecedent streptococcal infection mentioned here. Okay. So now this secondary prophylaxis is to be given with injection benzathine penicillin, which is given every 3 to 4 weeks. And the dose for children less than 27 kgs body weight would be 6 lakh units. More than 27 kg body weight would be 1.2 million units. So here this 11-year-old girl, the ideal weight would be more than 27 kgs, but I was told by the students that in all the options there was only 6 lakh units and not 1.2 million units. Okay. So if the girl is malnourished and her weight is less than 27 kgs, then we can take 6 lakh units. Okay. And the duration of prophylaxis, because there is no carditis or residual heart disease, then in that case the duration of prophylaxis would be for 5 years or till 18 years of age, whichever is later. So this is the best option out of the given options present here. Single injection of benzathine penicillin can be used for the treatment of streptococcal infection, but not for the secondary prophylaxis here. Okay. And if carditis is present or residual heart disease is present, then we need to give prophylaxis for 10 years or till 21 years of age. If residual heart disease is present, then even lifelong may be required. Okay. So moving on to the next question, what we have here is a 6-year-old male with a history of recurrent blood transfusions. That means some anemia is there, chronic anemia is there, with pain in hands and feet. Hemoglobin HPLC, high performance liquid chromatography, shows increased HbF, HbA2, and a peak is seen in the S window. So if you are getting a peak in the S window, that means the child is having sickle cell disease. So sickle cell anemia or sickle cell disease is the best answer out of the given choices. Okay. So this, friends, is a picture of the hemoglobin HPLC. You can see the HbF here. You can see the HbA2 peak here, and the HbS peak is so high that it is not getting accommodated in this sheet. So HbS peak is here, and this is diagnostic of the sickle cell disease. Okay. So diagnosis of sickle cell disease, on the peripheral smear, you can get evidence of hemolysis, sickle cell and Howell-Jolly body. So this is from our video and the notes. So sickling test can be done. Spleen biopsy can show gamma antibodies. Hemoglobin electrophoresis or HPLC is going to show you the HbS peak. While the confirmatory thing, you can do the gene defect, where the beta globin gene, we know 6th position of the beta globin gene, the glutamate is replaced by valine. You can demonstrate that. Okay. Next question. A neonate was found to have a TSH, thyroid stimulating hormone level, of more than 100 units per liter on day 4 of life. So that means the baby is having congenital hypothyroidism. There is no doubt about that. The TSH level is so high. USG shows eutopic thyroid gland. That means thyroid gland is present in its normal position. There is no ectopic thyroid gland. There is no absence of thyroid gland, or dysgenesis of thyroid gland is not there. So USG is showing a proper thyroid gland in its proper position. TSH is more than 100. What would be the next investigation? Whether it will be urinary iodine concentration. TRAB is the TSH receptor antibody. Thyroid nuclear scan. The fourth option I could not get, friends. If you remember, and if you remember the fourth option of this question, please write in the comments below. So thyroid nuclear scan is the best answer out of the given options, because in this case we need to know what is the underlying defect that has caused congenital hypothyroidism. For that, the thyroid nuclear scan is going to help. Ideally, it should be done using the radio-labeled iodine. If radio-labeled iodine is not available, you can also use technetium. Okay. And ideally, it should be done as soon as possible after the diagnosis, within 1 week of starting thyroxine. Or if it is not done at that time, then maybe later at around 3 years of age, you can give a trial of stopping thyroxine and then do it. So ultrasonography and technetium 99, or if iodine 123 is available, then that thyroid scan should be done for all babies with congenital hypothyroidism to get an idea of the etiology. Okay. So if the gland is eutopic or thyroid scan is normal, it indicates a possibility of temporary CH. So as we mentioned, at 3 years of age, you can give a trial of stopping the treatment and do the parameters once again. Okay. Now, first we do the ultrasound of thyroid gland. Here we have already done that. We've seen that there is eutopic thyroid, and then we do the thyroid scans, preferably using radio-labeled iodine. If not available, then technetium. If there is increased uptake, then we get evidence of endemic iodine deficiency. Okay. If there is reduced uptake, maternal antithyroid drugs is a possibility. Okay. Normal uptake, then we need to do a perchlorate discharge test to diagnose dyshormonogenesis. Okay. So thyroid scan is very important to come to the etiological diagnosis and is the best answer here. Moving on to the next question, again a very important topic which we've discussed so many times. An 11-month-old baby was brought with a history of incessant crying. On examination, a tender mass was palpable in the right lumbar region. An image of the barium enema study that was done is shown below. What is the diagnosis? So friends, can you appreciate a claw-like thing here? So this is called a claw sign or a coiled spring sign and is suggestive of intussusception. And this is a typical case scenario. In our videos and notes, again we have discussed intussusception when the clinical scenario where you'll suspect it will be sudden onset severe paroxysmal colicky pain. And baby of course is not going to say that the baby has pain. So there can be excessive crying and you can get currant jelly stools and you can get a tender sausage shaped palpable mass in the abdomen. And the barium enema shows the coiled spring sign or the claw sign. The next question, a 12-year-old male presents with bloating, recurrent loose stools and features of malabsorption. His HLA-DQ2 is positive. So HLA-DQ2 and DQ8 we know can be positive in celiac disease. And there are features of malabsorption also, like bloating is there, recurrent loose stools are there. So this child, if is a case of celiac disease, needs to be started on a gluten-free diet and that has to be given lifelong. So celiac disease, friends, the risk factors or the etiology are environmental factor due to gliadin, which is there in the wheat. Genetic factors associated, we mentioned as we discussed in our video and notes also, HLA-DQ2 and DQ8 increase the risk of celiac disease. Immunological factors, you can demonstrate the antibodies like anti-TTG, anti-endomycin antibody or anti-DGP antibodies. Okay, and lifelong gluten-free diet is the treatment of choice. Next question, a child presented to OPD with multiple episodes of loose stools and repeated vomitings. Okay, he was lethargic and not able to drink breast milk. Skin pinch was going back very slowly. Which grade of dehydration? So again, we've discussed it n number of times in our videos, in our notes, in the MCQ marathon, everywhere. Very, very important is diarrhea in children. So we know when it is no dehydration, the child is going to be well and alert, the eyes will be normal, tears present, mouth and tongue moist, and the child will drink normally and the skin pinch goes back quickly. While in some dehydration, the child is going to be restless, irritable, eyes will be sunken, the child will be thirsty and drinks eagerly and goes back slowly, the skin pinch. Severe dehydration, the child is lethargic like we had in the case scenario here. The eyes may be very sunken, the child drinks poorly or is not able to drink. So in this case scenario, the child was not able to drink breast milk, remember? And the skin pinch goes back very slowly, taking more than 2 seconds. So this, friends, the given case scenario is a case scenario of severe dehydration. And here to correct it, we need to give 100 ml per kg fluid and that has to be given intravenously. Ideal fluid would be RL with 5% dextrose. Okay, so the next question, a 2-year-old pre-morbidly normal, well-thriving child presents with sudden onset breathing difficulty while playing. Okay, chest X-ray of this child shows right-sided hyperinflation with normal left lung. So sudden onset thing and unilateral findings are there. Unilateral hyperinflated lung, the other lung is normal. Which of the following statements is true? So this appears to be a case of foreign body aspiration from the given case scenario. So child has developed acute laryngotracheobronchitis is not true. This is not a case of croup where you will get a, the low-grade fever can be there, a viral prodrome can be there, stridor can be there. So this is not a case of croup. Focal area of decreased air entry will be suggestive of foreign body. Yes, if there is a focal area where you're not getting air entry properly, that can suggest foreign body. In complete obstruction, ball valve mechanism leads to such condition. No. We know in a partial obstruction, partially obstructed bronchus, what happens? Air goes inside the bronchus. So partially obstructed bronchus, what will happen? The ball valve or trap valve mechanism will be there, where air can go inside the bronchus but cannot come out. So in this case, there can be hyperinflation. Okay. So complete obstruction will not lead to this condition. And flexible bronchoscopy is the management of choice? No. If such a foreign body has lodged in the bronchus, then rigid bronchoscopy is the management of choice. So best answer out of the given options is focal area of decreased air entry will be suggestive of foreign body. Okay, so foreign body aspiration, again, we have discussed in detail in our videos and the notes. And you can see unilateral hyperinflated lungs due to obstructive emphysema is suggestive of foreign body. The case scenario, sudden onset choking or coughing episodes. And, prompt removal by rigid bronchoscopy is the management of choice. Okay. Next question, identify this abnormality in a newborn baby. What you can see here, this is the umbilical cord attachment and this looks like the urinary bladder. So this is the trigone area and these are the attachments of the ureters here. So this is the urinary bladder mucosa exposed to outside. So this is urinary bladder exstrophy. This is not a case of omphalocele where you will get from the umbilicus a protruded mass covered with sacs will be there. Gastroschisis also no, and patent viral intestinal duct again no. So urinary bladder exstrophy, again we have discussed in detail in our videos. So urinary bladder protrudes from the anterior abdominal wall like you see here, and its mucosa is exposed. Umbilical attachment is displaced downward. Pubic rami are widely separated. Rectus muscle separated. Complete epispadias in males is there. And these babies are going to have total urinary incontinence is going to be there. In the long run, there's an increased risk of bladder adenocarcinoma. So you need to cover this area with a plastic film, and so that it doesn't get dehydrated, remains moist, and then surgery is the treatment of choice, of course. Next, you have a child with a history of recurrent urinary tract infection who presented to the OPD. X-ray finding is given. What is the probable diagnosis? So this, friends, appears to be a case of, what you can see here, the bladder is distended and both the ureters are, tortuous and distended. Okay. So this appears to be a case of vesicoureteric reflux. Okay. And vesicourinary reflux, we know, is a very important cause of recurrent urinary tract infection in children. Bladder diverticulum does not appear like this. In bladder diverticulum, you can see a protrusion from somewhere from the bladder. Ectopic kidney again will show kidney present elsewhere, and the normal anatomy of the urinary tract, like bladder, the position of the kidneys will get altered. Okay. Vesicocolic fistula will also not show a picture like this. So this is vesicoureteric reflux. So VUR is usually discovered during the evaluation of UTI. This again is a snapshot of the notes of the videos that we have discussed in prep. So it can remain asymptomatic, or there can be isolated fever, or there can be features of recurrent UTI. Bladder bowel dysfunction can be associated, and you can see it on a contrast VCUG or a radionucleotide cystogram. So here the MCU, the micturating cystourethrogram, is showing you the picture. Okay. The last question that we are discussing here, a 10-year-old boy with generalized edema and massive proteinuria. He was diagnosed as a case of minimal change disease. So we all know in children, the nephrotic syndrome most common cause is minimal change disease. True about this disease is light microscopy shows effacement of footplate of podocytes. No, we know on light microscopy, it is absolutely normal finding in minimal change disease. Electron microscopy can show this finding, but not light microscopy. Good response to steroid, yes, it is correct. And we know the drug of choice is prednisolone. More common in adults, no. Minimal change disease, more common in children. Non-selective proteinuria, no. Non-selective proteinuria is not this, mainly the albumin which is coming out. So the best answer is good response to steroids. So again, we have discussed nephrotic syndrome n number of times in detail in our videos also, in notes also, previous year questions also. So most common cause of nephrotic syndrome in children is minimal change disease. Okay. And in minimal change disease, kidney biopsy as such is not indicated. But if you do a kidney biopsy on light microscopy, there will be absolutely normal finding, while electron microscopy can show effacement of the food process of the podocytes. Okay. And the drug of choice for nephrotic syndrome, initial episode we said, is prednisolone. 2 mg per kg daily for 6 weeks, followed by 1.5 mg per kg alternate day for 6 weeks. Okay. And there is the treatment of the subsequent treatment of nephrotic syndrome will depend upon the course of the disease. So in frequently relapsing nephrotic syndrome, you just treat each episode. Okay. So in frequently relapsing nephrotic syndrome, or steroid dependent nephrotic syndrome, if the steroid threshold is low, you can continue low dose alternate day prednisolone for a long time. While if the steroid threshold is high, or there are features of steroid toxicity, then you can use levamisole or oral cyclophosphamide or MMF. In steroid-resistant nephrotic syndrome, again, in a number of times it has been asked, the drug of choice is calcineurin inhibitors like cyclosporin or tacrolimus. Okay. But in refractory cases, you can even use rituximab. Okay. So friends, these were the 21 questions recalled from pediatrics in the NEET PG 2022 exam. Again, highlighting the fact that pediatrics is, a very upcoming and very, very important subject, which is going to be a game changer in your NEET PG exams and in the upcoming competitive exams. You can see the questions were pretty straightforward, and I'm sure if your concepts are clear, your basics are clear, and if you've read and revised your important topics, you will surely have answered all these questions. So friends, please type in the comments below if you have any other questions which are there from pediatrics which I've missed, or if there is any change in any of the options or any of the questions, please mention in the chat box below, and I'll be happy to resolve all your queries. Thank you very much. All the best for your results. Keep working hard. God bless you. Thank you.